Case 38, a 55-year-old woman presents to the emergency department with confusion and lethargy. On physical examination, is found to be tachypneic and tachycardic, and her breath smells somewhat like nail polish remover. A review of her electronic medical record reveals that she was diagnosed with type 1 diabetes mellitus at 12 years of age. She is admitted to the hospital and treated for diabetic ketoacidosis, and her symptoms begin to improve. However, 4 days after admission, she develops fever, mucoid nasal discharge, and periorbital swelling. While cultures are pending, she is treated with empiric antibiotics but fails to improve. What is the most likely diagnosis? Myucormycosis. What is the microscopic appearance of the fungus involved in this condition? The zygomycetes are nonseptate branching fungi with wide, greater than 90-degree branch angles and large hyphae. By contrast, Aspergillus tends to have narrow, septated hyphae and branches in acute angles. What patient populations are at increased risk for this condition? The fungus is ubiquitous in nature and spores can be transmitted in air. Most patients are exposed to these spores several times per year, but an intact immune system is usually sufficient protection. Therefore, mucormycosis is typically seen in diabetic patients with poor glucose control or those with ketoacidosis. Neutropenic patients, burn victims, and patients treated with iron chelating drugs are also at risk. What is the pathogenesis of this condition? The fungi grow along blood vessels and invade their walls. Protruding hyphae are highly thrombogenic, resulting in ischemia and necrosis of distal tissues, which in turn provide nutrients for continued fungal growth. Necrosis compromises the integrity of the bony walls of the sinuses and the cribriform plate, allowing fungal growth into paranasal sinuses, the bony orbit around the eye, or the brain. This rhinocephalic form of infection is rapidly progressive and carries a high mortality rate. Other forms include pulmonary, gastrointestinal, cutaneous, and disseminated infection. What is the appropriate management for this condition? Surgical debridement of the infected and necrotic tissue is paramount. Reversal of the permissive condition, in this case ketoacidosis, should be initiated in conjunction with potent antifungal therapy and amphotericin B. However, despite optimal management, this condition still carries a high mortality rate.